One of the particular concerns about possible drug interactions is proton pump inhibitors. Lots of patients have gastroesophageal reflux disease, little heartburn, and many patients, millions, are on one of these agents to help with that. Some of them are on it really without critical need in terms of their symptoms. And because of that, I would always want to talk with the patient about how badly they need an agent for heartburn. And if it is something that is a real issue for them, certainly if they have a history of ulcers, or if it's something that really disrupts their life and heartburn is a major symptom, I would be inclined to try to keep that. On the other hand, many patients are on it but don't necessarily need to be on that. And frankly, I would generally prefer to have patients on a shorter acting agent like ranitidine, for instance, or take Maalox here and there and just try to keep that at a different time of day than the time that they're taking their EGFR inhibitor therapy. So the issue is that the bioavailability can be altered and actually reduced without the acidic environment. Another option that I've sometimes thought about is having patients take anything from perhaps an aspirin or vitamin C or orange juice just to have a local acidic environment if they really needed to be on it. Now that said, there is not a lot of evidence that there is a real clinical impact that is clinically significant for patients who are on a proton pump inhibitor. In one study, in particular with erlotinib, when they looked retrospectively at patients on a PPI versus not, there wasn't a difference in outcome. So it's something to be mindful of, and if patients don't necessarily need to be on a proton pump inhibitor, I'll hope to have them not on it. But some do need it, and it's just something we can factor in. And also know that there's a variability in dose, and the effective dose that they may be getting could be lower because of that.